So now we'll be discussing the third part of the RD Masterclass on vitrectomy and tamponade. So we studied in the first part about how exactly the retina detaches. And in the current era, if you have an uncomplicated reg detachment, you can either do a buccal, pneumatic, but more and more people are going in for vitrectomy. This can be done with or without an additional buccal element. So for a long, long time, we used to do 20 gauge vitrectomies, but now we have MIVS, the micro-incision vitrectomy system. And these are 23, 25, and 27 gauge instruments, which are developed and are used only when we operate nowadays. The size of the incision has gone down. It minimizes inflammation and post-operative discomfort to the patient, and the cutter port is come closer to the tip. So these have become more versatile instruments now. And gradually with time, it has indeed become the procedure of choice for most cases of retina detachment, especially pseudophakic retinal detachments. Why has this shift occurred? Because of technological advances, improved capabilities, greater safety with better instrumentation, reduced complications seen during these cases, and we as surgeons have become more comfortable with the procedure. They're important to know that certain factors will influence the decision whether we do pars plana vitrectomy or scleral buckling. There are few relative contraindications to primary scleral buckling, like the giant retinal tear, very posterior breaks, if you have advanced PVR, if there's vitreous opacity or vitreous hemorrhage. These are cases where definitely we prefer to do a vitrectomy, or there's some challenges putting in the buckling element, like if there's a very thin sclera, if there's prior a surgery for strabismus, squint surgery, if there's a glaucoma filtering bleb or devices. So these are places where we prefer to do a vitrectomy. When we do decide to do a vitrectomy, the surgical strategy should be individualized and based on the retina breaks. Still very, very important to find a break, like we learned in the first masterclass, the status of the lens. So what is the position of stability of the IOL? It has a very critical role during the operation. Sometimes if the IOL is very unstable, we need to remove the IOL also for the safety of the patient and so that it doesn't get displaced post-operatively. What is the condition of the vitreous gel? Is there PVD present? Sometimes if the PVD is not present, it makes the vitrectomy very, very difficult. And patients should be able to do the positioning, especially with the gas tamponade. Big advantage, of course, of vitrectomy is that you're directly relieving the VR traction, which is one of the culprits causing the detachment. You clear away the vitreous opacities or hemorrhages that occur. And even if there are multiple breaks in different quadrants, or if the breaks are anterior, posterior, etc., that's no problem. Nowadays, a lot of people have very expensive IOLs, multifocal and toric. So refractive error gets changed when we put a buckle, but with vitrectomy, that doesn't happen. So these are some of the advantages of a primary vitrectomy in regmatogenous retinal detachment. Some of the disadvantages, as you can see in this picture, is the positioning, higher cost, and of course, we can have IOP problems, and cataract progresses quite a bit after vitrectomy. So you need to counsel your patients that they probably will need a cataract surgery after some time. If we come to the procedure itself, we'll be showing a video about this, but basically you have the transconjunctival or transscleral entry. The belt buckle is optional. Sometimes it is very important to use it. So these are young patients, phakic patients, complex RDs, or patients with PVR. I think it's quite important to add a belt buckle, after which we do a co-vitrectomy and ensure that PVD is present. Posterior vitreous detachment is very, very important to create and extend. So if we see the procedure, then we have the base excision with scleral depression, the endo drainage, and then we do the retinopexy, which is important, and the exchange with whatever tamponade we want to use for that particular case. Now, there are some animations on how to do fluid exchange because this is one of the most important steps. So in the past, we used to have extendable flute needles. You can see this extends in and slowly the air comes in, fluid goes, and the retina is settled. Other technique which was very much in use was the sandwich technique, where we put PFCL posteriorly and anterior fluid now is going to come out with the air. So with the sandwich technique, we get all the fluid out. And nowadays, what we find most simple is if you don't want to use any other material, just tilt the head of the patient. So you visibly you turn the head of the patient and make the brake, you can see the brake most dependent, and then do the fluid exchange. And this, I think, works very, very well with most of the patients. So if we see this is a video, so we can see the co-vitrectomy. So although the retina is so mobile, you can see it's hardly moving, and where we can drain through the brake with the cutter. And this, as we drain from the brake, the retina gets less and less bullous. And this is what we described as our assistant is depressing and we are doing the peripheral base excision. It's very important to have a very high cut rate at this and a slightly low suction at this point because we don't want to create any iatrogenic breaks. And here you can see at the vitreous base, so we are only able to trim the vitreous, may not be able to pull it much in the periphery after at the vitreous base. Sometimes the brake has a flap and that doesn't let you drain very well. So you can trim it like shown. And then it's always nice to put an endocautery mark to kind of mark the position of the brake because after you do the fluid exchange, this may become invisible to you. So if you have a cautery mark, that always easy to guide you where the brake is. And then once the fluid exchange is done, this is when the retina will become flat. Sometimes there's some posterior fluid left that you don't have to worry about. That will get self-absorbed after some time. And then we do laser tamponade. We do laser barrage around the brake. And after this, the tamponade is what is put. So coming to tamponades, which I was discussing, this is very important. There are various gases or liquids which we may use. Sometimes for a very short time, filtered air may be also used. But most cases we use SF6, C2F6 we don't really have in India, but most commonly we use the C3F8. And most patients with superior pathologies or where positioning is possible, these are the preferred kind of tamponade versus silicone oil. So you can see in the diagram the three phases, the gas expansion phase, then it gets equilibrized in the second diagram or cartoon, and the third is the bubble dissolution. This happens on different times based on the property of the gas which we are using. So these are the various tamponades. Air, if you see, there's no expansion, and 5 to 7 days is the duration. SF6 has a little higher duration, expands to 2x, 2x times. And normally we use about 20% of it and stays for 1 to 2 weeks. C2FA6, which is popular in some countries like the UK, this is also slightly longer lasting, about 4 weeks. But C3F8 is what we generally use. It expands 4x time. Important to use the correct concentration, around 14%, but you can use between 12 to 15% based on your kind of comfort, and it lasts 6 to 8 weeks. Technique is also very important. You have to have two sterile filters on a syringe, and a non-expandatory concentration is very important. I think it's very important to check that you have the correct gas, because if you put the concentration of the incorrect gas, it can be disastrous for the patient. So please check the correct gas. And most important is tell the patient the precaution that he cannot undergo surgery under GA and he is not allowed to fly in a plane after gas. This is important. Sometimes we can put an armband also mentioning gases in the eye so that everybody is aware about this. Oil is used when there's a need for longer tamponade, normally 1,000 to 5,000 centistrokes available, and they should be removed. It's not good to keep oil for very long. 3 to 6 months is the ideal time, or before that the oil should be removed. So standard oil, you can see this always floats. It's lighter than water. 1,000 centistroke is easier to inject, but there's more emulsification. 5,000 centistroke we use in more complex cases, pediatric cases. And then they have another thing called heavy oil, which is like Tenseron 68. Now we use Tenseron Extra Oxane. And this is used for inferior brake tamponade. And positioning is not needed when we use this. This is because one of the most challenging situations are inferior RT. And because silicone oil has lower density of water, it floats up. and the surface of the lower retina periphery is not sufficiently covered by the oil tamponade. So a mixture of aqueous and humor and vitreous and growth factors are there, which is called PVR soup. So this is why reproliferation occurs in this inferior area. So heavier than oil tamponades have been designed to kind of make up for this problem, and patient can keep normal head positioning and face down position unnecessary. That's the advantage. And this is one of the ones which we use, the Denseron Extra. There's a little animation here.
We use heavy silicone oil like Denseron. Unlike routine silicone oil, this gives adequate support to the inferior retina, which is the most common site of reproliferation causing recurrences. See the case of this 45-year-old obese computer professional with a recurrence after scleral buckling as well as vitrectomy. He wasn't willing to position any more as he found positioning uncomfortable and he was worried about losing his job. So, after resurgery, we put heavy oil as a tamponade. This helped to comfortably stabilize his inferior retina. Post heavy oil removal, his retina was attached with 20 by 40 vision.
But you must remember that this is not a substitute for complete removal or traction. You have to do a very, very particular surgery. And if you need a superior tamponade and inferior, then this is not recommended. Also, the cost is quite high for this. Thank you so much.